is on breast cancer, and we have three areas we wanted to cover. First is we've made some substantial changes in how we're all going to practice in terms of GP referral guidelines. And the background to this is where 15 years ago, we had about 13,000 referrals a year nationally, and we now have 40,000 referrals. And we're trying to look at a way of reducing unnecessary referrals. And there's been a 3-year program of work that Martin O'Sullivan is going to talk to us about and explain to us. We're then going to have our second speaker is Siún Walsh, and Siún is going to talk about a very nice technical development in how we now localize small impalpable tumors. And this has been revolutionary because it means we're no longer waiting for wires to be put in an X-ray and delaying our operating lists, and it's a fantastic new advance. But Siún is going to tell us she's been the lead in Ireland in doing this, and we're all going to copy her in various ways. And finally, in relation to breast cancer, we're delighted that Jamie Martin-Smith, he's a colleague of mine here in Beaumont, an outstanding reconstructive surgeon. He has a large experience in this, and he's going to talk to us about who should be getting DIEP reconstruction. I'm sure that will give us plenty to discuss. So we're going to be done in 1 hour, it's 20 minutes per talk. And if I may ask Martin O'Sullivan, Martin has had the role as the lead of the NCCP breast group of surgeons, and he has spent 3 years with many colleagues on many disciplines developing this body of work, and we're delighted he's going to share it with us today. And just to give you a flavour, he's met GPs, radiologists, surgeons, hospital administrators, and it's been a huge body of work. He's going to talk to us about the development of breast referral guidelines in Ireland. Martin, it's over to you.
Okay, Arnie, can everybody hear me okay?
Yes, and we can see your slide.
And can you see my slide?
Yeah.
Okay, so let me know if there's any problems with the slides, please. So thank you for the invitation to speak this evening, Ronan and Arnie. So let me bring you back to 2009. The world was quite a different place back then. In fact, our Taoiseach was Brian Cowen, the UK Prime Minister was Gordon Brown, and George W. Bush started off the year as US President, and Donald Trump was a television star. And just to show you how things change over 20 years, this is a picture of a young upstart called Jonathan Sexton, who's abusing one of the true legends of Irish rugby, Ronan O'Gara, in this photograph. And he made his emergence in 2009. And the reason, obviously, the breast services have changed very dramatically since then. And the reason I'm emphasizing 2009, it was when the centralization process really came into being. This was something that was precipitated by a number of high-profile delayed diagnoses of breast cancer in particular. And up to that point in time, there was up to well over 30 hospitals in the Republic of Ireland operating on cancers and treating cancers. And this changed to eight hospitals for breast cancer anyway, back in 2009. So with the whole centralization process, there were numerous improvements, but we did end up with other problems, and it came down to the old chestnut of demand versus capacity. Now, part of the problem that arose related to a referral form, and this was the referral form that was developed back in 2009. It's very easy to use referral form. There was fax numbers up at the top of the form up here. But can I highlight this area here? You mightn't be able to see the entire referral form, but this is saying urgent referral. And a GP can tick one box, any box there, it takes 1 second to do, and the hospital was then obliged to give a 2-week appointment to the patient. And I'll come back to the unintended consequences of that now in a while. This is validated COH data from 2015 and 2016. So at this point in time, we're 6 or 7 years into the whole process following the centralization in 2009. And this is looking at the urgent waiting times in 2015, shown here in the red bars. Now, the KPI for this guideline is 95%. So in other words, we should be seeing 95% of the urgent referrals within 2 weeks or 10 working days. And we're not doing too badly overall in 2015. But in 2016, shown here on the green lines, we can see from the middle of the year onwards, it's fairly awful. We're persistently failing to meet that KPI. We've a similar story for the non-urgent referrals. Again, doing okay in the initial time frame of 2015, shown in red, but very, very poor in 2016 onwards. So does this mean that COH was performing poorly? Well, in fact, it wasn't. This is a new patient, the number of new patients that were attending the breast clinic from 2010 to 2016. And you can see a dramatic rise in terms of the new patients coming to the clinic. In fact, that was a 14% rise. Now, to show that graph in a different manner, the number of cancers over that time frame are shown here in red, and the figure is remarkably consistent. But yet, in the green bars, we're seeing over 3,000 extra patients to diagnose the same number of cancers over a 10-year period. Now, that's a 28% increase in terms of the number of patients coming to the CUH symptomatic breast clinic. It also represented a 36% increase in the number of patients requiring a mammogram and a 60% increase in the number of patients needing ultrasound. And you can see the trend here of increase over that time. And when these two lines are diverging, we have a serious problem in terms of the sustainability of the breast service. So it's very clear at that point in time, we need to get these lines parallel again to have a sustainable breast service, and preferably closer together. At the end of 2016 in CUH, we were seeing about 40 patients in the clinic for every cancer. And for the non-urgent patients, and remember this is a surgical clinic, the breast clinic, we were seeing 269 new patients to generate one operation, which was usually a lumpectomy rather than a cancer operation. And it certainly begs the question of whether this was an appropriate use of a precious surgical resource, not to mention an appropriate use of a very precious radiology resource. Now, this wasn't just a CUH problem. This is data from the 8 designated cancer centres at this point in time, and you can see fairly similar trends in several of the cancer centres. Huge increases in terms of the numbers of patients being seen. And going onwards from 2015 to 2019, again, the trend is emerging. Same trend, this is for urgent patients, in other words, the patients who should be seen in 2 weeks. And you can see each year, 2015 to 2019, this is Beaumont, again, the figures are increasing. And in several of the other cancer centres, we have the same problem. For our urgent patients, the yield is about 9%, 9 to 10%. So for every 10 patients you see in the urgent clinic, one of them will have a cancer. However, the figure is very different for the non-urgent cases. Again, we have a similar trend in terms of the numbers increasing. We're seeing well over 20,000 patients a year now with non-urgent breast problems. But the cancer yield in this group is 0.9%. Now, that figure is particularly important because that's more or less what BreastCheck gets when they start their screening program. So that yield is approximating that of the screen-detected population who have no symptoms whatsoever. Now, my next slide is probably the single most important slide in the talk. This is looking at the new patients attending the breast clinics from 2006. The guidelines came in 2008, 2009. They were fairly well embedded by 2010. This is 2015. And the last reliable year of data is on 2019. Obviously, 2020 was the COVID pandemic kicked in. And you can see a remarkably constant number of cancers during that 15-year time frame or 13-year time frame, but an almost doubling of the number of patients we're seeing in the breast clinics. And it certainly led one of my colleagues to come up with the term that we had developed a world-class mastalgia service. And that's all very well and good, but this was supposed to be a cancer program. So the issue with the breast clinics, the situation was clearly unsustainable in terms of the numbers attending the clinics. Many would have argued that this was out of control. The guidelines were out of date, and there was an extraordinary focus on the access KPI without any reference to the quality of the service. So a guideline group was developed under the auspices of the NCCP. You can look at the members of the group there. We have a good multidisciplinary team, several surgeons, radiologists, nurses, various administrators from the different hospitals. We have 3 general practitioners, a patient representative, various people from the NCCP with a wide variety of skill sets And we actually had a librarian as well. We dedicated access to a medical librarian, which was very important. And then different people attended by invitation at different points in time, such as Carl O'Keefe from the State Claims Agency. This was a big volume of work. Over 1,000 person hours were put into this whole process, between guideline developments, eReferral developments, implementation planning, and monitoring and evaluation planning. So a big volume of work that resulted in our national referral guidelines. Now, these were posted to every GP in the country about 4 weeks ago, and they were sent to all the people in the symptomatic breast services also. And let me give you one or two examples of what we have developed in terms of the algorithms. So when we looked at the evidence-based data as to what are the significant symptoms to suggest breast cancer, there was only one, and that turned out to be a breast lump. So no other symptom turned out to be reliable in terms of predicting breast cancer. Not only was it just a lump, it was a patient-detected lump rather than a GP-detected lump if the patient was attending the GP for another issue. So this was the most significant symptom, and the algorithm is very clear. If there's a discrete lump found by the GP, it needs to be referred to the symptomatic breast service. If a discrete lump is not found, the patient should be re-examined at a different time of her menstrual cycle and then sent in if appropriate. We've had a lot of problem with benign referrals into the breast clinic. And obviously, many people present with symptoms other than a lump. And this is to address such problems. Now, we have referrals here that are appropriate to be sent into the breast clinic on the upper line, such as skin dimpling, peau d'orange, nipple eczema to suggest Paget's disease, or indeed breast abscess. But we also have symptoms that are very important not to be sent in, not appropriate to be sent into the breast clinic. Sebaceous cyst, skin lesions, hidradenitis, and so on. These are not appropriate to be sent into the breast clinic, and unfortunately we've had them sent in quite regularly as a 2-week urgent referral. Now, a brief word on mastalgia. Breast pain is very common, but it is not a symptom of breast cancer. In fact, we have good quality Irish data from Galway and Beaumont to confirm that. And however, it is a big hitter in terms of it may account for up to 25% of referrals into the breast clinics nowadays. So we've an algorithm now for mastalgia on the clear basis that it is not a symptom of breast cancer. If there's a suspicious clinical finding, you go down the lump algorithm route and should be seen in the clinic. However, if there's a normal clinical exam, if the patient is under 35, they get routine measures to treat breast pain, such as evening primrose oil and so on. If the patient is over 35, they have those routine measures, and only if the symptoms persist and don't settle after 3 months should the patient be referred. And what's been agreed now is that we can do a mammogram only, in other words, a GP access mammogram. They don't need to come to the clinic, and that's the big change in terms of the mastalgia patients. Now, this is our eReferral form. I'm sure you probably can't see it all fully, but very importantly, the GP can't just tick one box anymore. Firstly, they have to tick a box to indicate that they have seen and examined the patient themselves, and then they have to give it, details about their findings, so that the triage is now done in the hospital and the patient can be deemed urgent or non-urgent by a breast clinician rather than a GP. And the smaller box here is just the mammogram only request. Now, what's important about this whole process is there is now going to be prospective data collection. KPIs are regarded as a crude instrument. Now, they will still be collected, but we're going to be looking very carefully at the number of patients that are deemed to be along the urgent pathway, the non-urgent pathway, and the mammogram only pathway. And if we spot any trends along the way that are troublesome, we should be able to intervene early to try and correct any troubling trends. And of course, the cancer yield is going to be detected as well. I'm aware you can't see the various boxes on this slide. Now, this whole process of keeping an eye on data in a contemporary manner is very important. Let me give you an example. This is our national electronic referrals for the breast service in 2021. So the orange line here is 2021, and you can see it's absolutely gone through the roof over the first 3 months. It's gone from 800 to 1200. Now compare this to the lilac color in 2019. So you can see there's been a dramatic increase in terms of referrals already in 2021. Now the 2020 data is shown here. Obviously this is the COVID lockdown, so that's not as reliable in terms of data, but we have a huge problem in terms of an increase in referrals this year alone. Now, this process, there are potential pitfalls here, and nobody is saying for a second that it's the solution to all the issues in the breast clinic. Obviously, the entire health system has a significant backlog related to the COVID-19 crisis, and the breast service is as bad as any other service in terms of that. So sorting out the backlogs is going to be a major problem. Our radiology colleagues do have concerns about these guidelines. They're particularly concerned about the GP access for mastalgia and the mammograms that are available to the patients here. They're concerned that this may result in an ad hoc screening service to the women of Ireland, which would not be appropriate. And they're also concerned about the COVID backlogs and so on. And of course, change is difficult for everybody. We all tend to be cozy in our current environments, so any kind of a change is difficult. But nonetheless, what's clear is the breast clinic, the numbers are unsustainable at the moment. We have put far too much emphasis on benign patients with the same yield as we get from the screen detected population. We need to start looking at our cancer patients again, increasing the yield there, and increasing services such as CT scans for the node positive breast cancer patients, which have been neglected in this whole scenario. This is the first time since the centralisation in 2009 that we have multidisciplinary national referral guidelines, and these are evidence-based guidelines. And hopefully they will enable us to regain control back into the breast clinic and to empower the service again. Thank you very much.
Great, thank you very much, Martin. A huge change, and we've only just started on the 1st of April. Martin, what would be your biggest, if I could just start the questions, and please feel free to type into the chat, what would be your biggest concern about this process?
Well, I think the radiologists have a valid concern, Arnie. So for example, they're concerned with the mammogram only scenario for mastalgia, that we'll end up having ad hoc screening for the entire female population. And that would be highly inappropriate. Their workload then would be unsustainable. I think the COVID backlog is another problem. So for example, if you're seeing 20 new patients in a clinic, and if 8 of them would typically be mastalgia patients, those 8 patients will not be coming to your surgical clinic now, but instead they will be backfilled with what you'd call the COVID backlog patients. So you'll still be seeing 20 patients. You'll still be generating imaging requests to the radiology department. So they'll still have to deal with 20 patients, and they'll have to deal with the extra 8 mammogram requests for the mastalgia only patients that the GPs will sort out. So that's a concern. I think the main issue here is we need to change the culture out there in the community so that GPs will reliably document the findings that the patients have. The notion of getting a 2-week appointment because your sister-in-law has breast cancer at the age of 75 is just completely bananas. And I mean, it's a huge, I can see Arnie, I can see Shun nodding her head. It's incredibly frustrating for everybody in the breast clinic at the moment.
What about should we increase the number of breast surgeons? Because it sounds crazy that you would see 40 people to operate on one cancer. That's not sustainable.
Well, I think if anything, if we want to develop this system and keep going the way we are, Arnie, what we need to be putting in place is breast physicians. It's an awful waste of surgical training having people just seeing mastalgia and benign nodularity in a breast clinic. And we should develop, if this is what we want to do, we should go down along the kind of gastroenterology route, who will do the scopes, and they'll send the cancers to the colorectal surgeons. And in the same way, if we want to do this, we should develop breast physicians that will send the breast cancers or the surgical cases to the breast surgeons. And in that situation, you'll probably need fewer breast surgeons. But what's clear is the current situation is in no way sustainable going forward.
Okay, let's any questions from our colleagues online. Do they want to type it in, or just you can ask a question? So we have a question there. The hand is up, and it's Vita Hamilton. Vita, what do you think?
I was just wondering, is there a role for advanced nurse practitioners to support breast surgeons or physician assistants in addressing some of the volume?
Martin, do you want to take that question?
Yes, Vida, I think there absolutely is. And I think some of the units around the country now do have some help from advanced nurse practitioners. I mean, they obviously have to be carefully supervised. This is part of a whole process that is also going to look at family history and the return patients as well, by the way. But, you know, running a family history clinic would be an ideal role for an advanced nurse practitioner, or perhaps a return clinic. So yes, I think we need to look at physician assistants, A&Ps, everything, and we have some GP physicians in CUH as well that has actually been quite a help in the clinic and has enabled us to keep it going, essentially, because it wasn't possible to keep it going without them, to be honest.
Okay, let's talk to Jerry O'Donoghue. You have a question, Jerry, from Waterford. If you unmute, Jerry.
Thank you, Martin, for all your hard work. I suppose I have an insight into having, we have now for 3 years, 2 physicians assistants, we might call them, who are GPs, and we're culturing an advanced nurse practitioner, and they're excellent. But the problem is it doesn't get you through more patients, because ultimately a consultant needs to supervise those ANPs or those GP or physician's assistants. So having an extra 5 or 6 physician assistants doesn't really mean you get through more patients, because ultimately each patient needs to be seen by a consultant unless you divest responsibility entirely to those new individuals. So they're not the absolute panacea or cure that one might envisage.
Sure, Jerry, and I entirely agree. But if you look at the data that I presented, so the urgent patients we're seeing currently, the cancer yield is about 1 in 10, which I think is reasonably acceptable. And that approximates all the patients that we're seeing before the centralization process in my data from 2006. What's happened since the centralization is we're now seeing an extra 22 or 3,000 patients a year with benign disease. That's very time consuming, and the cancer yield is that of the screen detected population. So what we need to try and do is change the culture out there of just referring everything in automatically for a 2-week appointment, and that's been a really big problem. I'm sure you have that down in Waterford as much as we have it everywhere else, you know.
Absolutely. Could I just ask one more question? I'm sorry to monopolize. I did type it in, but can an inappropriate referral now get through the electronic drop-down pathway from April the 1st? So if I'm a GP, can I send a 20-year-old in with breast pain still? Or does the electronic drop-down pathway stop that?
No, it doesn't stop it, Jerry, but you're perfectly within your rights to say this is an inappropriate referral. Please look at the new algorithms that we have developed.
Thank you.
And what the GPs in the group have said to us is this has now empowered us not to send in the inappropriate referrals. I think the big problem here in the country in general is we have a fairly toxic medical legal environment. So they felt obliged to send in, you know, virtually everything. But now there are clear algorithms that say, actually, you have breast pain, you don't need to send you in. I'm going to give you the routine measures like evening primrose oil and so on, make the dietary adjustments, and come back to me in 3 months' time. And the GPs in the group are saying this will empower us now to behave in this manner rather than send everything in, which has been the case up to now.
Wonderful. Great work, Martin. Great work.
Yeah, it's been a huge body of work and a lot of, as you say, over 1,000 hours of work with multidisciplinary teams trying to work out the best thing. It's evidence-based, so well done. And
thank you.
You know, congratulations also on bringing it in halfway through a pandemic. So
well, in fact, that's a very important point, Arnie, because we actually, in retrospect, we should have done it last year. We held off because of the COVID-19 pandemic. And in theory with this, we would have less referrals. And if we'd introduced it in last year, we would have a smaller COVID backlog. So it's unfortunate we didn't do it last year, but I guess we'll all look back on things with COVID that were a bit unfortunate at the time, you know.
Well done for getting it started anyway. Thank you very much for that really superb presentation. A lot of data, Martin, and thank you for all the work on it for all of us nationally who are going to benefit from your work. I'm going to move on to Siún Walsh. Siún has was one of our SBRs here, trained with us, went to Memorial Sloan Kettering and trained there, and has brought back nice technical innovations in breast cancer surgery. She's going to talk to us today about the best way of localizing impalpable breast lesions. I think more important, the amazing impact it's had on the logistical issues within running a symptomatic breast service. So Siún, you're very welcome, and thank you for the presentation together.
Great. Can everybody hear me?
Yes, we can. Thanks.
And can you see my slides that I'm sharing now?
Right, yes.
Okay, fantastic. So thank you so much for the opportunity to show everybody this new technique that we've been pioneering in the Mater Hospital. So I'm just going to kind of show you the journey that we've been on that got us to here. Now, sorry, there seems to be a little delay here. Okay, so what brought us to this point of needing seed localization? Well, anyone who's ever worked in breast surgery will know that without seed localization, the only option for non-palpable breast lesions that need to be excised is putting in a wire. This has numerous problems involved. The wire has to be inserted on the morning of surgery. An AM bed is required, which then isn't used till halfway through the day. A patient has to wait on the ward with a wire hanging out of their breast, which has lots of problems, and we get a lot of negative feedback from patients about this. It's very uncomfortable, and there's been dislodgement rates of up to 3% reported in the literature. And we've all had that situation where the wire becomes stuck in the blanket as the patient's transferred onto the operating table. All of these things cause massive problems in scheduling, and also because the wires can be quite long, it's hard to sometimes know where the tumor or the lesion sits along the length of that wire, and so this often leads to removing greater volumes of tissue than intended. So what is a Magseed? A Magseed is a paramagnetic low nickel stainless steel seed that's about the size of a grain of rice. When I was on fellowship in the States, we were using radioactive seeds, but these had a lot of problems with disposal and responsibility about who inserted them and how they were managed, and what happened if they got lost, and what happened if they could not be retrieved. So this magnetic seed can be left in lifelong now, and that's been approved worldwide. And so there's it avoids a lot of these problems. It's inserted with an 18 gauge needle that can be 7 or 12 centimeters long and deploys out through the end of that, and can be put in under ultrasound guidance, stereotactic guidance, or tomosynthesis. It can be inserted up to 30 days prior to the surgery before, but actually now you can put it in even longer beforehand. And so at the moment, we're actually placing them on the day of diagnosis or on the day that we decide to proceed with surgery. And it doesn't matter how long it takes you to get to that date of surgery, it'll still be there and shouldn't move. And so when patients present on the day of surgery, they're fully ready. They don't have any trauma. There's less movement through the hospital. These can be put in a very precise location, and even when they don't match up with the exact location of the lesion, the radiologist can give us exact detail as to the relative location of the seed relative to the lesion so that we can figure out where it is. These are not radioactive, and we use this Centimag probe, which is really essentially a very small MRI machine, which makes a loud noise when it's near the seed, and that shows us where it is. It's a little bit like using a gamma probe. There's very few contraindications. Apparently it can't be used if there's a nickel allergy, but we haven't had that situation yet. And also, if you're planning an MRI, it's better to place the Magseed after the MRI has been done, because it creates a lot of artifact. And so now I'm going to show a video of a Magseed procedure. And so this is a Magseed guided wide local excision, sentinel lymph node biopsy, and dome mastopexy. So this patient had a 22 millimeter invasive ductal carcinoma, which was triple negative and was node positive. And so she had neoadjuvant chemotherapy. And following this, her MRI and mammogram showed an excellent response. And so a plan was made to proceed with a Magseed guided wide local excision, sentinel lymph node biopsy, and a dome mastopexy. Sorry, the video is freezing on and off, but I'm just going to leave it alone and let it play.
We assume we might just talk through the key
Yeah.
video and let's see if it does with the Wi-Fi actually play eventually.
Oh, here we go.
Great.
So here you can just see, sorry, I think the Wi-Fi isn't good enough for this video at the moment. So when the patient is positioned, we check with the Sentimag probe to see where the seed is and make sure that we can detect it. She's having blue dye injected, and we've just marked out a crescent-shaped incision just superior to the nipple. That's the blue dye being massaged in. And now she's having deepithelialization of a dome shape above the nipple to just start the dome mastopexy. Now just moving along there. The deepithelialization, and then a skin flap is being raised. And here we're just using, and it's important to note that any metal on the table will actually interfere with the Sentimag probe, but we're using reusable autoclavable instruments for this part of the surgery, and there are lots available that aren't that expensive. So here you can see we're using the Langenbachs, and we also obtained some Babcocks. You do have to be careful that there's no clips or artery forceps just lying on the table or clipping the drapes together, because that will interfere with the signal that you get. And that was one of the things on the learning curve. It's a problem that you don't really get with the radioactive seeds, because using those is exactly like using the gamma, you use the gamma probe to detect them, so you don't have the problem with instruments. And here we're just delivering the specimen. And checking again that we still have the seed. The other problem you can get sometimes is if you apply too much pressure to the breast tissue, it can cause the seed to sort of pop out. But that's just all part of the learning curve. And just because it's freezing, I'm going to fast forward a little bit. You can see the specimen out there. And we're just checking again that we have the Magseed in position. And then we tend to get a specimen X-ray just to make sure that we do have the seed, and usually there's a clip also. And that's just the specimen X-ray showing the seed and the clip in the center, and our skin clips that we've used to orient the specimen. And so now I'm just going to move on. So recently we've just, our old SHO, Ed Murphy, wrote up our first 100 Magseed guided procedures, and it's just been accepted for publication in the Surgeon. It should be available online in the coming days. So we started trialing the seeds in November 2018, and we did 9 of them just to see how it would go. And it went so well that we actually implemented this fully from July to December 2019. And so amongst our first 100 cases, 72 were breast check patients, 28 were breast health. 91 of the seeds were placed under ultrasound guidance and 9 under stereotactic guidance. And we found that our re-excision rate of these lesions was 11%. So our re-excision rate was still completely acceptable in this cohort. And we retrieved all 100 Magseeds. We had 4 complications in this cohort, 1 hematoma and 3 infections. Our mean operating time was 38.7 minutes, and that was including the sentinel nodes, which some of the patients had. So that was, again, completely acceptable. And also our mean specimen weight was also acceptable. But the interesting thing was we looked at the readiness for theatre, and during the time that we implemented this, we compared this with our wire-guided localizations. And we found that the mean time for readiness for the seed localized procedures was 9:35 a.m. And for wire-guided procedures, this was midday. With the Magseed localized procedures, 73% of these patients were ready for theatre before 10:30 a.m. And actually, when we looked at the other 27%, it was usually due to bed availability or medical problems. But the wire-guided patients, none of them were ready before 10:30 a.m. So even in this short period of time, we could see that it was really having an effect on how our theatre day was organised and our efficiency. And then more recently, one of our radiology fellows, Laura Sweeney, has taken a look at our first full year of Magseeds in the Matter. And she looked at the time period from July 2019, when we fully implemented this, to July 2020. And in this time frame, we did 297 Magseed guided procedures. 76.7% were for biopsy-proven malignancy. And she looked at how accurately placed the seeds were. And actually, 2/3 of them were at or within the target. And of those that were not, the vast majority were within 5 millimeters of the target. And amongst those, there was only 10 out of the 297 where the seed was placed more than 10 millimeters from the target lesion. But in 7 of these, it was still possible to just indicate to the surgeon, using annotation of the post-seed placement mammogram, the position of the seed relative to the target, and no further localization was required. And only in 3 of these cases, so 1%, a wire had to be placed on the morning of surgery to relocalize the target lesion. And all 297 seeds were retrieved. And so now we're 2 years on from when we started this process. And I just checked our figures just yesterday. And between breast check and breast health in the Mater public hospital, we have done over 800 seed localized procedures. We found this to be a very easy technique with a very easy learning curve. We've had really positive feedback from patients, especially amongst those who in the past had a wire-guided procedure and now had a seed localized procedure recently. And in COVID, we found this technique to be invaluable because it reduced movement through the hospital on the day of surgery. And it allowed patients to have enhanced planning and easy scheduling. And it really helped with how we planned our lists during COVID. So in summary, we'd highly recommend it. And if anybody wants any advice about how to get this going in their unit, I'd be happy to, or any of us would be happy to help them afterwards.
Siún, that was great, really fantastic. Can I just ask you, what's the cost for another unit setting it up? I mean, how much do we need to pay for the Magseed device and the actual seeds? What's the startup cost?
So the Magseeds are about 270 euros a seed, but you can work out a deal with the company, which we did. If you were to buy everything without getting any sort of a deal, the Centimag probe itself is about 40 or 50,000. And to replace a Magseed probe is about 10 grand.
And the real question, have you transferred this to do it in the private hospital as well, or are you wired to private? Or
absolutely, all Magseeds in the private as well.
And my last discerning question is, tell me how easy it was to persuade your colleagues. Did they just buy into it, or were there any little bit that didn't want to do it straight away?
No, I think it was actually very easy. I think the cost was a hard sell at the beginning, just with hospital management, etc. We put a lot of business plans together. But when we could show the benefit to the patient, then it really was a no-brainer.
Okay.
And I'm really thankful that we had it during COVID, especially.
Okay, question from Paul Balf. Is there a potential problem with seed migration if inserted at diagnosis? So you put it in, you don't do your operation for 3 weeks. Can it move? And I want to add a little bit more detail to that question. Suppose you get a hematoma. Is the seed able to float around the hematoma, and by the time you do your surgery 3 weeks later it's sort of moved at least a centimetre?
So firstly, those little ridges that are in the seed really prevent it from moving around. And there has actually been one paper, not from our institution, but from somewhere in Europe, looking at whether seeds do migrate over 30 days of placement, and they don't. They seem to stay put. However, the hematoma issue is definitely a problem. So what we do is, if they got a hematoma from their initial biopsy, and we clinically or on a mammogram, or
There's a little bit of a problem with the Wi-Fi connection there. I just want to repeat that, Siún, then we go for our last question for you.
So if there is a hematoma caused by the initial biopsy, we wait for that hematoma to resolve before placing a seed, or if it's an urgent procedure like a cancer, then we do place a wire instead.
Okay. Last question from Rajesh Ray. He says, can metal instruments be used with Magseeds? Do you use mag tracer or blue dye? So tell me about the Langenbecks. Are they not metal?
No, so we got silicone Langenbecks and Babcocks. And they were actually quite cheap, and they're autoclavable and reusable, although there are disposable ones that are available also. You can still use your metal instruments for most of the procedure, just not when you're actually using the probe to check for the seed.
Okay.
So it's only that little space of time that you need to swap out your metal instruments. But I have to say that is an advantage of the radioactive seeds over the magnetic seeds, because with radioactive seeds, you can use whatever you want. And then to the second question, no, we do not use mag trace. We still use regular blue dye or technetium.
Okay, and if I see there's no other question in the chat, I have a final question. To your poorer colleagues up the road in Coolock, we can't afford a 50 grand for this Magseed, and we've gone with the cheap tag localizer, which is substantially cheaper. It's about 5,000. What do you think? Are we just the poor people getting by with another device? Or do you have any views on tag localization, which is slightly different? It's a radio signal. No.
So when we started this process, that tag localizer was not actually licensed in Europe. It was only being used in the US. I have seen it at conferences, and I have a few American colleagues who use it. So I'd be really interested to hear how you're getting on.
Okay, we'll come back to you another time. Thanks, Siún. Any final question for Siún? Anyone to pop the hand up, and any final questions? If not, Siún, great talk. Well done, well done on getting all your colleagues, and sounds like a real success in terms of the logistics in theatre, getting people to theatre earlier. Well done. I'm going to move on to Jamie Martin-Smith. He's our consultant plastic surgeon here in Beaumont. He's still the new kid on the block, but he's outstanding. All the patients love him, and he provides, in addition to our colleague Nadine Majmal, a super service with DIEP reconstructions. He's going to talk to us about breast reconstruction and DIEP reconstruction and who should have it. So Jamie, the floor is yours. Thanks very much.
Thank you, Arnie. Slides up and running?
Yeah, we can see them. Thanks, Jamie.
Great. So absolute pleasure to speak on the weekly webinar series, and thank you very much for the invite. You know, you gave me a fairly wide topic, and I could probably talk for hours on DIEP reconstructions, but I tried to narrow it down to a few things. So basically, the point I want to get across is DIEPS, in some ways are, and in most ways are, the gold standard reconstruction. There's, you know, implant-based reconstructions which certainly have their place in many patients, but I'm just going to reiterate my feelings on that. I'm just going to reiterate the importance of immediate reconstructions, and then I'm going to spend a bit more time talking about how we're trying to improve the DIEP flap. And then last, just mention a little bit about the symbiosis that there should be between plastic surgeons and oncoplastic surgeons, you know, typically like Siún, and people who do their own reconstruction. So in Beaumont, like Colin Power, Oh, sorry. So autologous reconstruction, it's widely thought to be, the gold standard. And in terms of aesthetic outcome and superiority of the lifelong results, it certainly is. But the big problem with DIEP surgery, from the patient's point of view, it's not without self-sacrifice. And because of that reason, it's not always the correct option. So the gold standard isn't always the best option. And that's where implant-based reconstruction comes in. Free tissue transfer nowadays, it's just expected to be successful. It used to be, that if you did an LD flap, that would, pretty much always survive, but a free flap was risky. Free flaps now should just survive. There should be no real issue. We should be losing about 1 in 200 or less. The big issues now are the donor site morbidity and early recovery, looking for secondary donor sites in slim patients. And then mainly, and one of the big things is resource allocation. So as Professor Hill knows only too well, if he sends me a patient for a DIEP, I take a significant portion of his theatre. And the last thing to mention, combined reconstructive approaches such as an LD and an implant are becoming less common, except in specific circumstances. And that's mainly due to the rise of ADM in implant-based reconstruction. There's many papers supporting this gold standard of DIEP flaps. That's JAMA Surgery in 2019, looking at long-term outcomes in implant versus DIEP breast reconstructions, showing the superiority. Just want to briefly mention immediate breast reconstruction. We all know that it gives better outcomes. You just can't get the same outcomes in delayed reconstruction because you've sacrificed so much by taking away skin and giving your radiotherapy before you get a chance to reconstruct, and you can't get these kind of outcomes with delayed. And there was a big study in the UK of 2,500 patients in 2019, the IBRA-2 study, and looking at patients who had either no reconstruction, implant-based reconstruction, or own tissue or flap reconstruction, and looking at the time to adjuvant therapy, so either chemo or radiotherapy. And while complications were certainly more common with immediate reconstruction, as we all know, there was no significant overall delay or increased time to adjuvant therapy. And I think that's just a really, really important paper. Now, there's another paper separate to this on triple negatives, which is one that I respect in that it shows that if there's any time to delay in triple negatives, they do worse. So I generally am a bit more careful on them. But this paper does show that we should really be considering immediate reconstruction in many, many, many of our patients, certainly including node positive and ones going for an axillary dissection. It's not a reason not to. Quickly looking at the ASPS statistics, 2012 there was 6,500 DIEPs out of 91,000, and you can see it slowly steps up every year: 7,000, 8,000, 8.5, 9.5, 9.5, and finally in 2019 it passed 10,000 out of 107 breast reconstructions, so around 10%. And then if you look at the UK data, this is an old paper, but in 2012, autologous reconstruction as percentage of immediate breast reconstruction was only 3.74. So why is it that DIEPs are the gold standard, we think, or they're so good, and why are we so far behind in percentages? Well, the first thing just to mention is it's obviously a patient decision. Implant reconstruction, it's faster surgery, it works for slim patients. There's no donor site, faster surgery. I got that the wrong way around, and it's a much easier patient decision. There's no self-sacrifice. And so when you look at DIEPs and how do we, improve, what we can offer, we have to target each one of these. So we need to speed up doing our DIEPs. And it can't be that it's a big ordeal to send one of your patients off for a DIEP surgery. It should just be a reconstruction, which it can be. It's not a crazily complex procedure, even though we might have sometimes said that. Now it's something that's just straightforward. So we should really be, planning these. We get CT angios, and it should be an aggressive plan A. So you pick your perforator on scan, you go straight to it, and you plow through all the other perforators as you get there. And it means you can raise them very quickly. So just a quick point here: 2 perforators coming out beside the umbilicus. They both look as good on that. But if you go down a couple of steps, you'll see that the one on the patient's left goes intramuscular, and the one on the right goes around the muscle. And that takes off about half an hour of the dissection. And it's those kind of things we should be doing. And Venkat Ramakrishnan in the UK published this paper on doing 3 routine free flaps in a single operating theatre, and that's where we should be aiming. He published another paper where they subdivided a DIEP flap into 100 small steps and figured out how they could rationalize and shorten each step to the point that they did 4 in a day. Anyway, so we're trying to emulate that in Beaumont. And that's a picture of us after we did our first 2 separate patients, 2 DIEP flaps, and you'll see on the time it's 3:30 in the afternoon and the room is clean and the beds are gone. So that's Nadeem Ajmal and that's myself. So we did 1 of each. So it's definitely possible to do 2 and certainly 3. So our next objective is to do 3 in a day. And once we're doing 3 DIEPs a day, it'll just show everyone that it's not this big ordeal of an operation, and patients aren't told it's an 8 to 12 hour operation or this kind of nonsense. It's a quick operation if it's done in centres that do lots and lots of them, and that's what we should be aiming for. Slim patients is another, big thing. People say, you need a bit of a tummy to a DIEP flap, and it's true to a certain extent, but there's loads of other options. So classically, we raise a DIEP on 1 single blood vessel, but you can take blood vessels from both sides and do bipedicals. You can put a couple of flaps into 1 breast, or you can use alternative donor sites. So just because someone's slim on the abdomen doesn't mean they're slim everywhere. And this lady had previous implants, had them taken out, and then had a breast cancer, super slim, and just really didn't want implants again. So she's not finished. She needs her nipple reconstruction, but you can see it's a big sacrifice for her. It's a big scar on the abdomen, but you can get the volume that you need to match the other breast. Bipedical flaps is a number of way of putting them together, but this is one of the pedicles from the left abdomen, from the right abdomen, and you can connect them up with micro connections and then connect them into the chest. There's a few different ways of doing it. The donor site morbidity, we reduce our fascial incisions, wound management maybe with pico dressings and things like that. Tap blocks to try and get early movement and get them out of the bed, make sure we reduce our risk of DVT, and then seroma management and avoidance of drains by quilting the abdomen using tranexamic acid. So this is fairly typical of my abdomen after I take off a bipedical flap. So that's the arcuate line. So I haven't opened anything below the arcuate line, and it's anterior rectus sheath, and I've gone through the muscle just splitting, and then the second pedicle is very small. And this is opposed to DIEPs of old, where it was opened the whole way down almost to the pelvis to try and get out the vessels. Again, if you've got a low perforator, you have to go low, but you can still do it through a very small incision through the fascia. And the classical thing we used to say is a 1% risk of hernias after this operation, but once you get to these small incisions, it's pretty much 0, the percentage. Use tap blocks to try and give them some long-acting local anesthetic so that they can get up early and mobilize early. So you can either do that ultrasound guided, or what I use is a blunt needle, and you can feel yourself going through the layers of the abdomen. Just a quick look at a paper looking at 1,200 patients when I was a consultant in the Marsden in London. 105 patients that were included. Return to theatre was 49. There was 2 total flap losses, and both those flap losses were in 8 complex primary operations, as in something went wrong in the first operation. It's important, what I'm trying to show in this slide is that the return to theatres, and then the return to theatres, 8 were the complex primary and 5 were the standard primary. And those 5 standard operations were all within the first 2 to 3 days, all within the first 48 hours. And so we felt then that there was a 0% risk of flap compromise after day 3 for standard DIEPs, and so early discharge was reasonable. It also showed it's a low risk operation, 0.16 risk of flap loss, and most return to theatres happen in the first 48 hours, which means that we can bring in ERAS protocols to try and discharge these patients day 3 and day 4. And currently in Beaumont, over 80% of my patients get out at day 4 or earlier, and I have had 1 2-day discharge. Lastly, just to talk about the next steps in Ireland, I'm a firm believer in specialty discussions. So oncoplastic breast surgeons and microsurgeons need to talk, and it's something that should be encouraged, in that a breast surgeon who's doing their own implant-based reconstructions or any reconstructions understands the importance of skin flap, either thickness or thinness if it's a high risk cancer operation. But also respecting anatomical, cosmetic boundaries and things like this. And I think there's a lot to be said for trying to set up a reconstruction MDT at either a regional or a national database where we all bring our problem patients, because we all have them. I think we need to be looking at multiple routine flap theatre lists as a standard. And then what I want to move to next is doing some innervated DIEP flaps, which is probably the next rung on the ladder. And then moving on to free vascularized lymph node transfer, which would make sense for some of our lymphedema patients who need a delayed DIEP. Thank you.
Jamie, thank you very much. That was superb tour de force. I mean, it's incredible the data you're presenting. 80% of your patients getting out after 4 days for a DIEP, and proof of principle, 2 DIEPs can be done the day before half 3. If you get to 3 in a day, that will be just incredible. So a lot of progress made, and I think it's institutional memory and the ability doing the same thing each time is what's really, really driven it forward. This is open for questions. Happy anyone who wants to pop their hand up and ask Jamie a question directly or type it into the chat. Anyone want to come in with a question? So, Jamie, can I ask, you know, how plastic surgeons, how many of them, how many DIEPs do they need to be doing, or is it how many free flaps does a plastic surgeon need to be doing them competently?
I think, to be honest, the way it's going, unfortunately, it's getting, you know, it's getting so focused that to be, you know, doing DIEPs this quick, you pretty much need to be primarily be a breast microsurgeon, which is what I see myself as, and you know, Nadeem would see himself as that as well. Head and neck free flaps and other sort of free flaps is not quite as interchangeable, because to be honest, head and neck and lower limb is much more complex and difficult, and there's much more issues with vascularity of the flaps, etc. So it's a slower and more tedious operation. But the DIEPs really are the same every time in terms of decision making is the only thing that changes in terms of which perforator to take and make that decision early. But the more you do, the quicker you get at that. In terms of number per year, you know, you go to the meetings and, you know, some of the international guys talk about doing, you know, 60 to 100 free flaps a year would be the standard of what you should do. I think that's pretty hard to do here. I think you should be aiming to do up to 50 a year. And certainly with bilaterals becoming more common, that's going to be easier to do.
So who will you not do? Who will you not do a DIEP on? What about a smoker? There's smoking. Will you do them?
I probably would offer a DIEP to a smoker, as long as they understand the risks. I mean, I would sooner offer a DIEP to a smoker than an implant-based reconstruction, because one thing goes wrong. If one thing goes wrong with an implant, you get a little bit of a wound dehiscence, a little bit of skin loss, your reconstruction's gone. I mean, there's the smokers. There's a little bit of evidence to say that they have a higher rate of anastomosis failure, but it's more just wound healing and things which you can tolerate. Of course, the ideal is not to have a smoker, but I have done DIEPs in smokers, and it's not an absolute no. So for me, who do I not offer DIEP to? Very few. If they want to use their own tissue, I'll either use a DIEP or something else, and I'll find some way of doing it.
Okay. Our president, Professor Ronan O'Connell, that's a question. You're muted. Still on mute, Professor O'Connell, just unmute.
While there's a gap there, there's 2 questions there. There's one prior abdominal surgery. So that's it's a classic misnomer that if someone has had previous C-sections and appendectomies, they can't have a DIEP flap. You know, we do a CT angiogram and 9 out of 10 of them still have the vessels there, and there's no problem. Might be harder to do a bilateral because you have to discard some of the scarred areas, but in general, doesn't matter if they've had abdominal surgery. And oftentimes, someone with abdominal surgery is the perfect candidate, because especially multiple abdominal surgeries, because they have all sorts of scars, and you can excise all those scars, use the good tissue for a breast, and then they have one nice small, well, not small, neat, I would say, scar.
Okay, I see our president is unmuted. I'm glad that was a technical.
It's very unusual for me to be muted, I have to say, but there you are. And can I thank all 3 presenters? I have to say, I found all 3 presentations really, really very, very focused and interesting, and of relevance to all of us practicing the generality of surgery. So well done to all 3. Question I have really is for Jamie, and that relates to patient-reported outcome assessment, because at the end of the day, it's a very technical tour de force, and congratulations on your results. But at the end of the day, what do the patients think? Do they think it's better than the simpler Are people happy who've made the decision? And have you compared patient-reported outcome measures between the simpler reconstruction methods and the DIEP flap?
So there's a huge bank of data on this, but the classically implant-based procedures have an equal or sometimes even a higher rate of satisfaction in the first couple of years. But universally, all the papers show that as the years go on, the patients are much happier in the DIEP flap group. However, they always have the dissatisfaction of their abdominal scar, which they don't have. The classic way the classic thing to say is this: there's a huge cohort of patients who want their implants swapped out for a DIEP flaps, and that's becoming a much more common phenomenon. And does that give us definite data? It doesn't really, but it is interesting to see when you do take implants out of someone that has a reasonably good result and you put a DIEP flap in, they're so tolerant of the abdominal scarring and the 6 weeks recovery, just because the breast feels much more natural and normal and the tightness is gone. So there's a load of proper data, but also there's a lot of simple patient data. When you meet them, they're always very happy.
And if I may, just a supplementary, and the sensation loss on the anterior chest wall?
The sensation on the anterior chest wall, you mean in the mastectomy flap?
The DIEP is not sensate.
Correct, yeah, but most of the mastectomy skin isn't sensate either. So if you do an immediate reconstruction using implant, it's not particularly sensate either. Patients do, they get some element of touch sensation back randomly through random innervation of nerves, but innervated DIEPs are proven in multiple studies to give some sort of reinnervation back to the central paddle in the center of the breast in immediate reconstruction. The sensation of having own tissue is different to the sensation of touch sensation of the skin, and the proprioceptors that would be attached to the new breast by autologous tissue is felt to give better feedback of where the tissue is and give more normal sensation. But no, you can't return normal sensation to the anterior chest.
Thank you, Arnie, and thank you to all three speakers.
Thank you.
Just to finish, there's a question here in the chat. Is there any difference between minimally invasive laparoscopic and open DIEP flap? I think there is a massive, I'm not quite sure. Maybe Jamie, you might like to take that question.
So yeah, I mean, the robot has been used and laparoscopes have been used to harvest the vessels underneath the fascia. I think, to be honest, my fascial incisions are almost as short as a robotic incision. Having kind of played around with the robot in the Marsden, it's such a faff, and it would double your procedure time by so much. You still have to take the skin and you still have to take the fat, so you can't avoid all those scars. Unfortunately, there's no way of doing it without scarring.
Okay. All right. Well, look, we're just after 7 o'clock, so can I just thank our three speakers? Martin, a superb talk about changes in the process of referral. Shun, really nice operative technique, and Jamie, brilliant work in reconstructive surgery. Can I thank all of you? I think it's been a fantastic webinar, and I'd like to hand back to our president to close out for today. Thank you very much.
And as I said, thank you to all presenters, and thank you, Arnie, for chairing and bringing it together. And as always, I thank Laura, our Vice President, for putting together the program, and for the backroom team for supporting us. Good evening, and look forward to seeing you this time next week.
Thank you.
Thank you.